The recommendation is approval on this item. Please come forward, unless you change our minds.
Kristen Barlow on behalf of the California Mental Health Directors Association. CMHDA has worked closely with the administration on this plan. However, we would, similar to the conversation we had earlier about EPSDT and Prop 30, we would like to see the administration include in the May revise an estimate of what they believe it will cost counties to comply with the new requirements that will be rolled out as part of this new system. As you know, and as was discussed by CSAC earlier, Proposition 30 does require the state to provide funding to local governments anytime there's a new requirement, even an administrative directive that affects one of the realigned programs. So we'd be interested in seeing that be reflected in the May revise. Thank you.
Okay, thank you very much.
Carol Schroeder, California Alliance of Child and Family Services. Thank you for approving the request. That was our first recommendation. We've been working on with the Department of POS and really appreciate both their efforts and their enthusiasm. We would say that we think that we could actually begin implementing some of the data collection elements that are already being gathered by the state and by the counties, so we could kind of jumpstart this a little bit quickly. But as we move forward, I think it's going to be really critical that we assure that there's some statewide uniformity of measures. Otherwise, it's going to be very difficult to take a look around and see how different. This is all about access to services and what services kids are getting, and being able to determine that, in fact, there's equal access throughout the state. And then finally, that there be the adoption, after we get this done, and I have no doubt that it's going to be a really effective system, that there be a real transparency in terms of the reporting of the data. And the best model I know for that is the way the CDSS does it with their, with the Center for Social Services Research and the online availability of that data, and it's reported out to the legislature every year. And something along those lines we think would be really useful. Thank you.
All right, thank you very much.
Move to approve.
We have a motion to approve that item. And I agree. We have 2 ayes. Thank you very much. All right, next item, please. Implementation of SB 82 and SB 364.
And that will be me.
Hello.
So
are you just as enthusiastic?
I'm about enthusiastic about pretty much everything we do. So
excellent.
So just a brief update on SB 82 and SB 364. So essentially, I think Ms. Jackson through the OAC gave a pretty comprehensive review or overview of these 2 initiatives. We're looking or seeking positions to help us support the implementation of SB 82 and 364. So with the additional treatment and crisis stabilization beds, as well as the work associated with designating facilities, we're seeking just a few supportive analyst positions to help us with the licensing and certification, the 5150 designations, as well as the ongoing certifications and compliance monitoring that we do. So thus far we've received, I believe, 10 requests from counties, but we're not sure if we can't tell if they're tied to SB 364 or not. We just wanted to note that no matter if it's 5150 or not, any new facilities coming on board have to go through an application process for licensing or certification. So we do have that workload. We have a heads up from some private corporations that we might be receiving a large packet of applications. That's something that we've been told. And one example is LA County. They've told us that we'll be receiving a large portion of program certification applications related to SB 364 and 82. So we're not sure what portion of these will be 5150 designations, but as I mentioned, we'll have to do a whole application licensing and certification process. And we're also getting quite a few calls and inquiries from different counties or different entities. So we're actually having to do quite a bit of ramp up implementation work in preparation. So we're answering questions, we're going to be developing information notice, we're going to be developing regulations, We've had to redesign forms, which that process in and of itself opened up quite a few questions. So we're already feeling a workload starting to hit us. So.
Okay, thank you very much. Any comments by Department of Finance or LAO on this item? LAO?
We agree with the staff's recommendation to hold this item open. As we heard from the Health Facilities Financing Authority, their grants under SB 82 are still being finalized, and we should have those final numbers by May. And also, there may be additional information available about the potential for increased workload for the department.
Okay, thank you very much. Any public comments on this?
Good afternoon.
Good
Randall
afternoon.
Hager for the California Psychiatric Association. My comment is maybe a question and a comment, because I'm not aware that with the SB 364 program that there was any requirement to report data, such as we do currently for 5150s. And so if new facilities come online and they are receiving people, will the same kind of data be collected and reported out as we also have for 5150, 5250, 5350s, all those kinds of things?
That's a good point.
I think it's a good idea if we do.
It's a very good point.
Yes.
Yes.
Yeah.
Thank you very much. Yes, Senator Money.
Just on the licensing timetable, how long does it take once you receive these applications, and assuming they meet muster, how long does it take to turn around?
I would have to
approval?
get back to you because I'm not as familiar with that process. Karen, do you know from having been a director by chance? Okay, no, I'd have to get back to you on that.
Yeah, I think it'd be good to know what is
Sure.
the window, 3 months or is it a year, in terms of getting these new services online as quickly as possible, and if necessary, possibly allocating or shifting some resources in anticipation of an influx of applications. Thanks.
All right, thank you very much. This item is recommended to stay open. So moved by Senator Money, 2 votes to keep the item open. The next item is number 7, Drug Medi-Cal Overview and Major Issues. Welcome to you again.
Let me just give you a brief overview of Drug Medi-Cal. Currently, what we have is 5 different methodologies. One is the narcotic treatment program, which you heard a little bit already about, and that provides outpatient methadone maintenance and a minimum of 50 minutes per month of face-to-face counseling. We do have the residential treatment services currently for perinatal, and you've already heard some speakers talk about the issues we're having with the IMD exclusion. We have outpatient drug-free treatment services, which provides counseling and rehabilitation services, and then we have intensive outpatient treatment, which is provided 3 hours a day for 3 days a week, so it's more intensive. With the Affordable Care Act that became effective January 1st, 2014, we are opening some of these up to not just be perinatal, but to anyone who has Medi-Cal, and thus we're having difficulties because of the residential treatment issue and being able to have new providers provide that service.
The next question you ask is related to the program integrity issues. And as you all know, I've testified several times in front of this committee as well as other committees in the Senate and the Assembly. And what we've uncovered as an administration within the Drug Medi-Cal program in terms of the program integrity and the fraud and waste and abuse is just simply unacceptable. And we have been working since last year on ways to root out the fraud within the program, and have taken several different action steps. To date, we have suspended over 75 different providers. That encompasses about 235 provider sites. We've referred many over to the Department of Justice to take action. We are also doing, and I've released to the legislature a top-to-bottom report on all the different steps that we're taking. We will talk more later about the waiver, and one component, and I don't want, and you asked, the waiver is about an organized delivery system that encompasses how do we provide the most cost-effective, appropriate care, patient-centered care, and an accountable system. But one piece of that will help with program integrity, but we aren't doing it solely because of program integrity. In terms of the steps that we're taking in general, I want Karen to go into some more detail about some of the other steps we're taking to make sure that we, this important, valuable benefit is focusing on those who need it, and we root out the fraud within the program.
So as previously mentioned, one of the divisions within the department, the Audits and Investigation, did a full top-to-bottom that was released January 10th and is posted to the website. There's a number of recommendations on that list, and I wanted to assure you that we are working through all of these recommendations. And just to give you an idea, there was a recommendation to decertify all of our non-billers. Previously in the drug Medi-Cal arena, you could become a certified provider and then you were never certified again. And so a number of these providers have gone out of business or have merged or relocated. We still had them active on our rolls. We have now gone through and cleaned that all up and have deactivated all those who have not billed in the last 12 months. We are working very closely with Audits and Investigations regarding providing some training on what outpatient treatment looks like and how to be able to identify fraud and to really give them more in-depth training on the drug Medi-Cal programs. And then we're also working with our county partners to revise the county contract for next year to implement more monitoring and oversight requirements from the counties.
And then the final question you asked us in this area is around whether what we're doing in terms of temporary suspensions, what's resulted in terms of access. We at a state are not, have not identified or had issues. That being said, we were just having our waiver stakeholder advisory group. From our providers that have raised, that's not necessarily the case. It's something I think as we get into looking at how we organize the delivery system and their entry points, that we hope that we can have better mechanisms to identify, especially for this population that might just turn, rather than seek out additional assistance, might resort, concern from providers, go back and into using drugs again, that we have other mechanisms to track. And that's part of, again, as we create a stronger organized delivery system, that might be ways to deal with that. So we will continue to work on trying to monitor, but focuses on rooting out those providers that are inappropriately billing our system.
So just one other thing to mention is regarding access. We have mapped out both for the state of California, and then we have highlighted one particular county to look at where each provider is located by modality, so we're able to see if there really are gaps in services. And then we're also working with CADPAC, the alcohol and drug provider or administrators for the county, and doing a survey with them in order to be able to determine some and collect some data on if there are access issues.
Thank you. I think the access issues were among some of the most pertinent questions. You mentioned 75 suspensions. Were those concentrated in any particular part of the state? I know we have population distribution that's not equal throughout the state, but can you summarize?
Yeah, they're concentrated in Southern California, primarily in Southern California.
So again, where you find a concentration of these violations and suspensions, is that also an area that you look then to try to determine access so that people don't fall off treatment programs?
That's exactly right. And I think that's a good segue into the questions around access under the waiver, and maybe we could talk a little bit about how we will, as we're going forward and under a waiver, we would monitor access. That would
Great. Should we just see, does LAO or Department of Finance have any comment up to this point? And we do have public comment. Do you want to comment now or wait until they address the waiver?
Do the waiver now.
Okay, great. Thank you.
So on January 10th, the department also announced its desire to pursue a waiver. We've been looking at the 1115 waiver, which is a demonstration project. We've already started to have some conversations with the feds regarding this proposal. And really, what happens now is there is no continuum of care and there's no coordination of care within the drug Medi-Cal system. And so if you are someone seeking treatment, you can go to a provider. If you're going to a residential treatment facility and you don't like the rules because of that one provider, you can just leave and find another provider that has different rules. And so there's no one that's really monitoring to see that there is coordination of care and determining that maybe you don't need residential treatment, maybe you need intensive outpatient treatment with some supportive housing. And so what we're looking to do with the waiver is to be able to demonstrate for counties who want to participate in this process that they could opt in and they would have the full continuum of care, and then have some oversight and monitoring of how that client moves through the system and goes to a lower level of care. One of the other questions that is asked is regarding the stakeholder in the process within the waiver. We, as Director Douglas said, we did our first waiver advisory group meeting yesterday. Previously, we had talked to the stakeholders and asked, how do you want to do this work? We have committed to having it being an open and transparent process, and they all decided they wanted to get into a room and just do the work for 8 hours. And so we have scheduled 3 days. Yesterday was our first day. We are calling this our WAG, for a Waiver Advisory Group. We do have a number of members that sit on this advisory group, but we also have it open to the public. We had phone access yesterday, so the members of the advisory group were able to talk about the issues, and then we did open it up after each issue to the public and then those on the phone. We are planning on doing some sort of a summary of what was discussed yesterday, and being able to post that to the website and send that out, because we do understand that committing 8 hours at this busy time of year is difficult for some folks and they can't attend. And so we want to be real transparent with this process and to have a summary of what was discussed. Just to go through some of the members of the advisory group, CMHDA, NCADPAC, CADP, which Helene was already speaking here, COMP with Donna Brownsey was already speaking here, CSAC with Kelly Brooks. We also very excited to have UCLA on board, because there is an evaluation component to this waiver, and so UCLA talked to us yesterday about some of the things that they're thinking that they could do to evaluate whether the waiver was effective and efficient. And then we also have CSAM, which is your physicians who are specialists in addiction medicine. And so those are the people who are on the waiver group. So our next meeting is April 15th with a follow-up on April 30th, and we'll continue to work through this process and keep you posted.
And with this large number of stakeholders, how will you prevent the tail from wagging the dog?
Well, CMS is the ultimate one who says yes or no to the waiver. So what we're doing is collecting feedback. I can tell you yesterday there was a lot of like-mindedness regarding some of the issues. There was only a couple where there was real dissension, and one of the issues was basically out of our scope of the waiver. So that's how we're going to continue to move forward. I think it's important that everybody be in the room to talk about these issues, because at the end of the day, what's really important is how this benefits the client and that the client gets the best treatment that we can provide.
Well, thank you. And I was just trying to make light of your acronym, but I appreciate that explanation.
You're good. There were a few other questions just quickly around, again, back to access. We really believe that this waiver will improve access. Part of creating an organized delivery system is our ability to both monitor at a state level requirements that we have, whether it's on our mental health plans, our medical plans, to make sure they're monitoring and providing appropriate access, which we don't have in a current fee-for-service any willing provider system. And we believe that will be strengthened through this system. There are requirements, very much concerns from some of our providers that selective contracting will restrict access, and we would say the opposite, that it creates requirements on the all modalities. The counties have to provide all the modalities, sufficient number of providers to meet the needs of the population, and they can't just arbitrarily withhold contracts if there's need for additional providers to meet the access. In terms of are we doing this because of the expansion of the benefits? And there are many different reasons, and one is the expansion. The expansion of the benefits is coupled with the expansion of the population. We're bringing in a childless adult population, over 1 million childless adults and more, many of them whom have substance use disorder issues, into a system. It's going to mean a lot bigger substance use disorder system and need for care, and we believe this is the time to start organizing it, both in terms of bringing on more benefits, which do have general fund risks since the state is paying for these additional benefits, not the counties, as well as the population, coupled with a need to create an organized delivery system that complements AB 109, the work that you all did on reforming the correctional system. Many are coming out of the correctional system into substance use. So all these are other reasons. And then finally, while it's still in the early stages, as you heard about it, is our need to tackle concerns around the residential benefit. We can't do a true continuum of care without residential benefit, and yet we have problems with the IMD, and it's looking like a potential way to get around the IMD is through a waiver. And so all these come together as many different reasons why we need a waiver.
Great. And you talked earlier about program integrity and retrospectively the suspensions as we move forward and presumably expand access. What does the department, how do you envision guaranteeing program integrity?
So we see this through a stronger, and this is again looking at what we've done on the mental health, a strong state-county partnership where the state, we will still be responsible for the certification process and making sure that all providers meet certain requirements and continuing to recertify, but the counties will be playing a stronger role, and we're starting to pilot this in a couple counties, starting with San Mateo, where they will go out and do the licensing, reviewing on being the ones and being able to know what's going actually on the ground level out there to make sure that they meet the licensing requirements, and then going on and monitoring and having a better feedback loop. So we're strengthening that state-county relationship. So a waiver does not by any means take the state's role away. We see, given what we've seen in this program, we're going to continue to play a strong oversight role with providers as well as monitoring our counties. I don't know if anything more to add on that.
Is there any danger in these programs of an economic incentive for the provider, keeping a consumer in a program where maybe they should be graduating to another type of program or service?
Well, I don't know if there's the incentive, but what part of what was discussed at the waiver advisory group, and really as part of this continuum of care, that you're creating an assessment of, and there were discussions about whether it's a single point of entry or a single assessment, and those things we'll work through. But as a consumer, you're being assessed at what your plan is to move through and step down the system into a lower level of care. And so to the extent we can create a true organized delivery system that lays out that continuum and what are the right steps at the beginning, that's what we're trying to do.
And there was overwhelming comments yesterday about using a standardized instrument that you can give to a client and multiple times throughout their treatment that will help guide you with what the appropriate level of care is, and it is an evidence-based practice. Currently, some counties use it, some counties don't, and so we would like to build in that into the waiver so that there is a standardized way of looking at where the client is best served.
I appreciate that. And again, I think the concern is sometimes the client or consumer is not going to be the most sophisticated advocate for themselves. And if there's an economic incentive for a provider to keep somebody in their program, there needs to be some checks and balances where perhaps through the consumer advocacy groups, but also through the state monitoring, those bad actors get identified and the consumer is protected. We're going to go to public comment, but first, anything from LAO, Department of Finance? Please come forward. Thank you for your patience.
Thank you, Mr. Chair. Tom Renfrey with the County Alcohol and Drug Program Administrators. We have been very actively working with the department and with providers over the past, well, over a year in terms of strengthening and improving the drug Medi-Cal program. The goal is to build a high-quality program that can really deliver the newly expanded services that we have, so that these are not just on-paper benefits, but are really delivered in the state and in the counties. We strongly support the department's application for an 1115 demonstration waiver, not only to address the IMD issue, which I spoke about earlier, but also that would give counties the ability and the opportunity to develop an organized delivery system for substance use services within their counties that we think will improve care and increase efficiency, while at the same time granting and guaranteeing access for all individuals who need these services. So we are working with the department and very supportive of moving forward with this waiver. Thank you.
Thank you very much. Next.
Mr. Chairman, Helene Meshar, on behalf of the California Association of Alcohol and Drug Program Executives, CADP. The association has not yet taken a position on the waiver itself. We're waiting to see what actually the department does decide is going to be in the waiver. One of the two things that we are very interested that should be in the waiver is the waiver request for the IMD exclusion, and secondly for the detoxification, the residential detoxification. Those are two important things that need absolutely to be in the waiver. We are participating in the stakeholder process that the department has set up, and will continue to work in that. The one issue I would like to also address is the integrity issue, and we think that one of the ways to ensure integrity in the program is through the standards that are set by the employees and all employees in the programs. And to that extent, we think that the state should reclaim its authority for testing, certifying, and disciplining employees who work, because they're the ones who, as Karen Baylor was saying, are the ones, if there's going to be a standardized instrument to measure people who are coming into the programs in terms of their assessment of their levels of need for substance use treatment, that the staff also has to have high levels of integrity and standards. And we think that the fact that the state has delegated out the responsibility for the licensing and certification of the staff could be improved by bringing that function back into the state. So thank you.
Thank you.